Welcome to the deep dive. Today we're getting into a condition you might well encounter, Meralgia Paraesthetica.
That's right.
Basically, it's when a specific nerve in your outer thigh gets irritated, causing things like numbness, tingling, maybe even burning pain.
Mm-hmm.
We've gone through the sources to pull out the essentials, really aiming to make this clear for revision or just general understanding.
Absolutely. It's all about distilling that key info, making it stick. So Meralgia Paraesthetica, what is it exactly?
Okay, definition time. What are we talking about here?
So at its core, it's about the lateral femoral cutaneous nerve, or LFCN for short. This nerve gets compressed or irritated somewhere along its path.
LFCN. Got it.
And that compression usually happens near the inguinal ligament, that band in your groin area.
Okay.
When that nerve gets squeezed, you feel those symptoms, the numbness, tingling, or burning, specifically on the outer part of your thigh.
Outer thigh only. That's important. And this LFCN, where does it actually come from? What's its job?
It's a sensory nerve, which is crucial. It deals with feeling, not movement. No weakness involved.
Okay.
It starts from the L2 and L3 nerve roots in the lower back. Then it travels kind of behind a muscle, under some fascia,
Right.
and then makes its way either through or under that inguinal ligament. That's the key spot.
That potential pinch point.
Exactly.
Yeah.
After that, it spreads out to supply sensation to the skin on the outside of the thigh. So think LFCN, think outer thigh sensation, L2, L3 origin.
Okay, makes sense. Outer thigh symptoms, LFCN compression, often at the inguinal ligament, sensory nerve from L2, L3. We've even got a visual description people can look up.
Wow.
What actually causes that compression, though?
Well, the main mechanism is that physical pressure on the LFCN, usually within or right by the inguinal ligament.
Like you said, the pinch point,
Yes, and lots of things can contribute to that pressure.
such as?
Well, obesity is a common one. Extra weight, especially around the abdomen, can increase pressure there.
Right.
Also, tight clothing. Think tight belts, waistbands, skinny jeans even, digging into that area.
The classic tight trousers issue.
Exactly. Pregnancy is another big one. The weight gain, the postural changes.
Hmm.
And then you've got things like scar tissue from previous surgery near the hip or groin, or even just direct trauma like a blow to the hip or thigh area.
Okay, those seem fairly common causes. Are there any less obvious ones?
Yeah, occasionally. Sometimes structural variations in the pelvis might play a role, or much more rarely, something like a pelvic tumor pressing on the nerve path.
So mostly mechanical compression, but keep those rarer things in the back of your mind. Who tends to get this more often? What are the specific risk factors we need to know for revision?
Definitely some groups are more at risk. We've mentioned obesity and pregnancy. Those are key.
Right.
Also, anything increasing abdominal pressure like tensocytes, which is fluid buildup,
Okay.
direct trauma to the hip-thigh area, as we said. And then there are surgical causes.
Like what kind of surgeries?
Things like pelvic osteotomy, certain spinal surgeries, laparoscopic hernia repairs, even bariatric surgery has been linked.
Interesting. Hernia repairs, too.
Yes, and in kids, those abduction splints sometimes used for Perthes disease can be a cause.
Good one to remember for pediatrics. What about activities? I saw sports mentioned.
Yeah, sports involving repetitive hip flexion or sustained pressure in that groin area. So things like gymnastics, football, bodybuilding, even just really strenuous exercise in general.
Okay.
But it's also important to remember that sometimes you just can't find a clear cause. Those are the idiopathic cases.
Right. Sometimes it just happens.
Yeah.
So we know what gets squeezed and why. What's the actual process, the pathophysiology? What's happening to the nerve?
It's fairly straightforward, really. The compression disrupts the nerve's normal function.
Like stepping on a hose pipe.
Exactly like that. It impairs the nerve signaling, leading to those altered sensations, the paresthesia, the numbness, the pain in the area it supplies, which is that outer thigh. The key is that physical entrapment or pressure, usually around the inguinal ligament.
Okay, clear. But, outer thigh symptoms aren't only Meralgia Paraesthetica. What else could it be? This is vital for differential diagnosis, right? Especially for exams.
Absolutely critical. You've got to rule out other possibilities. Diabetic neuropathy is a big one. Nerve damage from diabetes can cause leg symptoms.
Okay.
Then there's lumbar radiculopathy, a pinched nerve in the back, like sciatica, but sometimes presenting more laterally.
Right. Referred pain.
Exactly.
Yeah.
Hip joint problems themselves, like arthritis, can sometimes cause pain that feels like it's in the thigh. Other peripheral nerve entrapments further down the leg need considering too.
Yeah.
And even vascular problems like peripheral artery disease, though the symptoms might be a bit different.
So a good list to work through. How common is this condition overall? What's the epidemiology look like?
Well, precise figures are a bit hard to come by, but it's generally thought of as relatively uncommon.
Not something you see every day, then?
Probably not every day, no. It affects all ages, but it seems to peak in middle age, say 30s to 40s. And interestingly, it seems slightly more common in men.
Ah, okay. Middle-aged adults? Maybe more men? Any other patterns?
Sometimes it can affect both legs, though usually it's just one side. And there seems to be a higher incidence in people with diabetes.
Diabetes again. That keeps popping up. Do we have any rough numbers, like incidence rate?
There's an estimate of around 4.3 cases per 10,000 person years.
Okay, 4.3 per 10,000.
Yeah.
So, relatively rare, but not vanishingly so. More in men, rare in kids. Maybe M for male, M for meralgia.
Yeah, if that helps it stick.
Okay, so let's get to the patient experience. What are the classic clinical features? What does someone feel?
The absolute hallmark is those sensory symptoms, strictly confined to the anterolateral or outer aspect of the thigh.
Just that patch.
Just that patch.
Yeah.
So numbness, tingling, often described as pins and needles or a burning pain. Some people also find the skin becomes really sensitive, hypersensitive even, so light touch or just clothing rubbing against it can be uncomfortable or painful.
That sounds annoying. Does anything make it worse?
Yes, typically activities that increase pressure on the nerve or stretch it. So prolonged standing, walking, sometimes even just lying flat, anything that puts pressure near that inguinal ligament area.
Okay. And is there anything specific on examination we should look for?
The pelvic compression test is really useful here. You apply firm pressure just medial and below the anterior superior iliac spine, that bony point at the front of your hip.
Oh.
If pressing there reproduces their typical symptoms, that's highly suggestive of Meralgia Paraesthetica. Think press there, feel it there.
That's a great clinical sign.
Yeah.
Anything else, what should we not expect to find?
Crucially, no motor weakness.
Yeah.
The LFCN is sensory only, so leg strength should be normal. Also, reflexes are usually normal, and the symptoms can really vary. Some people have mild intermittent discomfort, others have quite severe constant pain.
Okay, sensory only, outer thigh, pelvic compression, test positive, no weakness. Sounds like a fairly clear clinical picture if you know what to look for.
Yeah.
How do we confirm it then? What investigations are needed?
Honestly, the diagnosis is primarily clinical. It's based heavily on the patient's story, the history, and the physical exam findings, especially that pelvic compression test.
So often no fancy tests needed.
Often not. But sometimes tests can help, especially if the picture isn't entirely clear or you need to rule out other things.
Like what?
A diagnostic nerve block can be very helpful, injecting local anesthetic around the LFCN, often guided by ultrasound now.
Ah, ultrasound guidance. Good point.
If that temporarily relieves the symptoms, it strongly supports the diagnosis. It's diagnostic and therapeutic, potentially.
Makes sense. Any other tests?
Nerve conduction studies can sometimes be used to assess the LFCN's function directly, though they aren't always abnormal even when someone has symptoms. In select cases, MRI neurography, a special MRI focused on nerves, might actually visualize the nerve and show compression.
Okay.
And of course, you might need other tests like blood tests for diabetes or imaging of the hip or spine, but that's more about ruling out those differential diagnoses we talked about.
Right. Ruling out the mimics. Okay,
Yeah.
so let's say we've made the diagnosis. How do we manage it? What's the treatment plan?
The first line is usually conservative. Focus on relieving symptoms and modifying those risk factors.
So the simple stuff first.
Exactly. Advise avoiding activities that trigger the pain. Suggest wearing loose-fitting clothing, avoiding tight belts or waistbands. If obesity is a factor, then weight loss is really important.
Lifestyle changes.
Yes, and simple over-the-counter pain relief, like paracetamol or ibuprofen, might help take the edge off.
Okay, and what if that's not cutting it, if the symptoms persist?
Then we move on to other options. Corticosteroid injections around the nerve, again often ultrasound-guided, can reduce inflammation and provide significant relief for many people.
The nerve block, but with steroid added.
Precisely. And if the pain is severe, chronic, and really impacting their life despite these measures, then surgery might be considered.
Surgery. What does that involve?
Usually it's a nerve decompression surgery, where they basically release the pressure on the nerve, freeing it from whatever is trapping it, often around that inguinal ligament area. It can be done from above or below the ligament.
Okay. Are there other non-surgical options besides the injections? The sources mentioned a few more things. Good to cover for revision.
Yeah, definitely. So for those idiopathic cases, besides removing compressive things like belts, we might try medications aimed at nerve pain.
Like what?
Things like certain antidepressants, tricyclics like amitriptyline, or anticonvulsants like gabapentin or pregabalin. NSAIDs can be tried too.
Okay, nerve pain meds.
10SS machines, transcutaneous electrical nerve stimulations, sometimes used alongside pregabalin, can offer some relief, and physical therapy can be beneficial too.
Physical therapy. What kind?
Techniques like nerve mobilization, myofascial release around the hip and pelvis, specific stretching exercises, addressing any underlying biomechanical issues.
Right, a multi-pronged approach. And you mentioned ultrasound for guiding injections, but it can help with diagnosis too.
Yes, ultrasound can sometimes visualize the nerve itself, maybe see if it looks swollen or compressed, and it helps ensure the injection goes exactly where it needs to.
Very useful tool then. So, lots of options before considering surgery. What's the overall outlook? What's the prognosis generally like for Meralgia Paraesthetica?
Generally, it's pretty good. Most people find their symptoms improve significantly with conservative management.
That's reassuring.
It might take some time, maybe weeks or months, for things to settle down completely, and some people might find the symptoms come and go a bit intermittently.
Okay. Are there any long-term problems or complications we should mention?
Complications are rare, thankfully, but in some cases, particularly if it's severe or long-standing, people might be left with chronic pain or persistent numbness or tingling.
Which could impact function.
Potentially, yes. It could lead to some functional limitations or just a reduced quality of life due to the ongoing discomfort. That's why proper management and follow-up are important to try and minimize those risks.
So, keep an eye out for worsening symptoms.
Definitely. Any sign of increasing nerve issues or symptoms that aren't responding would warrant further evaluation, maybe rethinking the treatment plan.
Okay. So, to quickly summarize the key takeaways for everyone revising this,
Yeah.
Meralgia Paraesthetica. It's that sensory disturbance, numbness, tingling, burning on the outer thigh.
Check. Lateral femoral cutaneous nerve compression, usually near the inguinal ligament.
Got it. Risk factors like obesity, tight clothes, pregnancy. Remember those?
The diagnosis is mainly clinical history and exam, especially that pelvic compression test. No motor weakness.
Right. Management starts conservative lifestyle, loose flows, weight loss, maybe simple pain meds.
Then move on to injections, nerve pain meds, physio if needed. Surgery is reserved for severe, resistant cases.
And the prognosis is generally good, most improve with conservative steps.
Exactly. It's a distinct condition, important to recognize in someone presenting with that specific outer thigh pain, and usually manageable.
Perfect. A great overview. And if you are revising for the MSRA and found this deep dive useful, definitely head over to pastthemsra.com and also check out firstarea.com for loads more resources.
Yeah, really useful sites.
Thanks for joining us for this deep dive.